Depending on the time zone that you are joining us. Good morning, good afternoon, and good evening. Welcome to the EFSUM webinar event titled Multi-parametric Ultrasound, the one-stop shop for the management of patients with chronic liver disease from theory to practical hands-on, supported by Samsung. My name is Jun Sun-woo, Director of Global Clinical Research Group at Samsung. Before we start the webinar, I would like to make a few announcements. In order to give the speakers and the audience the best possible atmosphere for an online lecture, we have set the program where we have limited the audio-visual to be transmitted one way. However, the audience is able to interact with the speakers through the chat box, which is located at the right lower corner of your screen. Please note that the contents of the lecture is the property of the speakers, and we ask you to not record this webinar. To those who have given Samsung the permission to contact you, we will be providing you with a link to the recorded version of today's webinar for educational purpose only. Also, I urge everyone to take part in the survey at the end of the webinar to help us better understand your educational needs. Now, without further delay, I would like to introduce you to our chairperson of today's webinar, Professor Vito Cantizani. Vito is the chairman of Ultrasound Unit at the Policlinico Umberto, University of Sapienza, Rome, the Vice Dean of Medicine and Dentistry of University of Sapienza. He is the president of SIUM and the honorary secretary of EFSUM. He holds an editorial position at the Ultrasound, European Journal of Ultrasound. He is part of the expert panel of EFSUM that published the European Guidelines on Liver Elastography, CUS in liver, and non-liver CUS. He has published close to 300 papers in peer-reviewed journals, co-authors more than 25 chapters of international books. Without further ado, please welcome my close friend Vito, everyone.
Thank you, June. Good evening, good morning, good night. I don't know how to say to all of you, but however, although we are not close and in the same room, I feel that we are close sharing this experience. I thank Samsung and especially June for inviting us, for organizing this webinar that it is a new one, a new type one, innovative one. I'm very proud because in EFSUM, we launched the webinar some years ago. And then together with Fabio, we prepared several guidelines. Right now, the new idea is to try to show you also not only theory, but the practical hands-on. And this EFSUM endorsed webinar is entitled Multi-parametric Ultrasound, the one-stop shop for the management of patients with chronic liver disease, from theory to practical hands-on. And there will be 3 lectures, one from Fabio Piscaglia. Professor Fabio Piscaglia is very well known. He's a very good friend of mine. And secondly, he is one of the most important researchers in the world. Actually, he is a full professor in internal medicine. He is the chairman of internal medicine unit in University of Bologna. He published, I don't know how many papers, and most of them are the most cited in the world. And today, he will talk about is liver disease only a liver disease? And he will try really to give us the overview of what is right now the clinical background. Then I will talk about how multi-parametric liver and carotid evaluation may be done with the new softwares, and 3 videos showing you the practical hands-on provided by myself and my PhD student and resident and great cooperator, right arm, as we used to say used to say Daniele Fresilli. Therefore, it's my pleasure right now to introduce the first lecture from Fabio Biscaglia. Please, Fabio. Sorry.
Thank you very
I have
much.
to remind all of you, sorry, Fabio. At the end of any lecture, there is time for 1 to 2 questions. However, at the end of the whole sessions, then we will have more time to address your curiosity and to give advices, tips and tricks on how to do it. Please, Fabio.
Dear Vito, thank you very much. Too much kind introduction. So I will try to focus from the clinical point of view as a hepatologist and also expert in ultrasonography. All of you know that the liver has several functions different from other organs, and there are mainly metabolic functions related to the excretion of toxics, to the metabolism, and therefore it's not too difficult to envisage that it has reflection on other organs, and this is becoming more and more common in recent years. If we focus at first on the liver itself, we know that we have chronic liver disease, which are one of the most common diseases worldwide, and there are several causes. We know that we have chronic viral hepatitis, hepatitis B or C. We have alcoholic liver disease. We have non-alcoholic fatty liver disease, which will be part of the focus of today. And we have autoimmune liver disease and also hereditary disease and other diseases. Regardless of the etiology, usually the process is a transition from a healthy liver to an inflamed liver, to the development of fibrosis, which usually is categorized into 4 different classes. So no fibrosis is a healthy liver. And then we go to the mild fibrosis, moderate fibrosis, severe fibrosis, and cirrhosis. And usually when the liver comes at the stage of cirrhosis is when the big problems start. Currently, the most common cause of death of a cirrhotic patient is liver cancer. However, there are other conditions which might lead to death, which are variceal bleeding related to portal hypertension, hepatorenal syndrome, which also is a consequence of portal hypertension, as well as ascites. We also have terminal liver failure and hepatic encephalopathy. There are some exceptions to this stepwise progression, which is the occurrence of a primary liver cancer in case of non-alcoholic fatty liver disease and in case of chronic hepatitis B infection. Under these etiologies, the patients might develop liver cancer without going through the step of cirrhosis. So already at the stage of a mild, moderate, or severe fibrosis without cirrhosis, liver cancer may occur. So this is to be kept in mind because these are patients who deserve surveillance under certain conditions, even if they don't have cirrhosis. Just to make an overview of the different etiologies leading to liver cancer that I mentioned is the main cause of death of cirrhosis, therefore this well reflects also the causes of cirrhosis, is that between 2004 and 2008 and in the fifth year, 2009 to 2013, so these are 2 periods of 5-year terms, we've seen that in Italy there was a trend to a decrease in the cause of viral etiology, but at this time, strikingly, there was an increase in a number of cases of non-alcoholic fatty liver disease, whether on its own or connected with alcohol intake, so a combined condition, which stepped from about 1%, 2% to about 9%. And at the same time, we have an increase in cryptogenic cirrhosis. So this means that this was not the fact that some cryptogenic cirrhosis were previously categorized under non-alcoholic fatty liver disease. There is actually there was a trend towards an increase in more chronic liver disease related to the metabolic syndrome. And we will see later what this does mean for our patients and our ultrasound approach. So having this in mind, the natural history of chronic liver disease, it is clear that we must detect these conditions early during their course in order to prevent future courses, development of cirrhosis, development of complications of cirrhosis. We have to put a strategical plan of therapy before these diseases go to cirrhosis. So to treat the virus or to ask the patient to lose weight, to treat diabetes, whatever is needed. So usually we start from the incidental detection of abnormal liver enzymes in patients who are not aware of having any liver disease, or detecting hepatitis B or C, or having a personal history being at risk of liver disease. For instance, an excess of alcohol abuse, drug addiction. Usually these patients receive abdominal ultrasound, which is helpful to rule out liver tumors as a cause, even metastatic liver tumors, which might sometimes determine an increase in liver enzymes, and also to detect the presence of fatty liver, or to detect whether there is already cirrhosis or not. These patients also undergo laboratory investigation to establish the etiology of liver disease and degree of liver function. With ultrasonography, with conventional ultrasonography, one might say the patient, unfortunately, you have already cirrhosis. And in this case, any patient with cirrhosis in the past had to receive upper GI endoscopy to screen for high-risk varices and start a 6-month interval follow-up to detect early HCC. Whether in case there is no clear cirrhosis, the question is how much fibrosis, and usually in the past, this patient requested biopsy. However, there are unsolved issues that ultrasound alone is unable to answer. We have detected the lesion, but is that malignance? Is it primary lesion? Is it a metastatic lesion? Or sometimes after liver laboratory investigation and abdominal ultrasound not detecting fatty liver, we have found no etiology, but might be nonetheless non-alcoholic steatohepatitis, even if there is no bright liver. And in this case, is biopsy really needed to stage the fibrosis if there is chronic hepatitis without cirrhosis? Can we spare some endoscopy? With conventional ultrasound, all these answers are no. Unfortunately, we are unable. But today, we will see how the innovations in ultrasound have answered several of these questions. So the first question is, a focal liver lesion was found. Should we refer the patient to someone else, to another technique, or may ultrasound be enough? Ultrasound is fortunately enough because we don't have conventional ultrasound alone. We have contrast-enhanced ultrasound. We have guidelines, and not only we are able to establish a diagnosis of hepatocellular carcinoma, but according to the current liver reporting system of the American College of Radiology, this LIRAD system, we can even classify lesions with contrast according to the risk of being an hepatocellular carcinoma. And I was happy to contribute to the development of this system, working in the core group, writing these recommendations. And also in Italy, we were able to produce strong evidence supporting the use of CUs in this condition. And this very large study with more than 1,000 nodules led to the update of the European Association of the Study of Liver guidelines about hepatocellular carcinoma that nowadays recognize the use of ultrasound as a potential tool, contrast-enhanced ultrasound as a potential tool to establish a diagnosis of hepatocellular carcinoma. You see now that contrast-enhanced ultrasound is a technique entitled to establish a diagnosis, even though usually CT or MRI are preferable because they are more panoramic. They can study not only the liver, but also extra hepatic presence of lesions like abdominal lymph nodes, chest lesions. Therefore, contrast-enhanced ultrasound has a potential, and this is to be combined with radiological technique, but we should not stop to ultrasound alone. Ultrasound has a great potential when we consider also additional technique. Second question, we have not detected a bright liver, but we have not found chronic viral hepatitis. There was not alcohol intake. There are no hereditary causes. There is no autoimmune disease. So is this a cryptogenic disease? How often does ultrasound alone could miss a fatty liver? These were studies in which patients apparently, I would say subjects, not patients, apparently healthy because they had normal liver enzymes. So theoretically, they were completely healthy. They received biopsy because they were candidates to living liver donation. And as you can see, histology detected fatty liver in 29%, whereas imaging detected fatty liver in 20%. This means that about 9% of these 200 patients could detect fatty liver only ultrasound. And this shows that most of these cases were of mild severity of fatty liver. So we can conclude that unfortunately, conventional imaging, including ultrasound, may miss mild steatosis. Therefore, a negative ultrasound scan cannot rule out on its own the presence of mild steatosis. This was confirmed by other studies, again on living donor candidates, because these are the few healthy subjects who receive a histological proof of their liver. And again, there was a higher than expected presence of histological abnormalities, mostly steatosis. So this was confirmed. But at least in overweight obese patients, because these were also all healthy patients, mainly lean normal weight patients, because they were studied as potential candidates for living liver donation. And we know that obese subjects cannot donate a part of their liver because they are at surgical risk. Therefore, we might expect that at least in obese subjects, if we don't see fatty liver, we can rule out non-alcoholic fatty liver disease. Unfortunately, even in obese subjects, you can see that the negative predictive value of a normal liver scan is not very high, and therefore is unable to detect mild fatty infiltration, usually between 5, which is the threshold to establish an increased fatty accumulation, and 20 to 30%. When the fatty liver infiltration is more than 20 or 30%, then ultrasound becomes highly sensitive. So there is this gap in which ultrasound alone is unsatisfactory. Can ultrasound do something more? Yes. In the recent years, we have seen innovations, and now we have new techniques like the capability of ultrasound with new softwares and new technology to measure signal attenuation. And you know that the liver fat, the fat attenuates more than the normal liver, but not always our eyes are able to quantify this attenuation. And this can be done by new ultrasound softwares. And also this can be quantified by tissue scattering. Therefore, there are new tools based on ultrasound which are able to detect the presence of fat infiltration, and these are expected to contribute to detect fat infiltration in patients in which ultrasound is unable to detect, reinforcing the possibility that these patients are not cryptogenic, but are patients with non-alcoholic fatty liver disease, non-alcoholic steatohepatitis. Moreover, in the future, the quantification might help to detect the efficacy of treatments, even losing weight, or even more when we will have drugs to treat non-alcoholic fatty liver disease, which would decrease fat content in the liver. We expect that these tools might be helpful to quantify the decrease. Like we measure blood pressure, we take drugs to lower blood pressure, then we go again to measure if the blood pressure has decreased enough. Probably these tools will help in the future to do the same for treatment of fatty liver infiltration. So we have now seen how ultrasound with new technologies can help in contributing to detect tiny amount of fat, and we also to establish a diagnosis of cancer, but also we need to graduate to grade different stages of fibrosis, not only before we come to the cirrhotic situation, but also in cirrhotic patients. Not all cirrhotic are the same. Usually the categorization was based on hepatic venous pressure gradient. However, this is invasive and expensive, and therefore it has limited availability. And also liver biopsy, which was considered the gold standard, is not perfectly accurate due to the possibility of sampling errors, and also is invasive. Most of the patients don't like to receive it, and it cannot be utilized as spread. With the spreading of the situations of chronic liver disease and liver abnormalities, we cannot propose to all patients biopsy. So what can be done? This has become helpful ultrasound with the use of ultrasound elastography. So we can do more than conventional ultrasound. Elastography is a more recent technique. The first guidelines were released by EFSUM in 2013. I was happy to coordinate the first consensus conference in Bologna in 2012, and this led to the first edition and to the second edition from EFSUM that was released just a couple of 3 years ago, and that was the consensus conference in Bologna. We have now different techniques. I'm not going now to explain the various techniques because each on its own will require too much time. The first one was transient elastography with pre-work scan, which is on a separate equipment, while other subsequent ones that are under puncture wave elastography or bidimensional elastography with different techniques are now embedded in ultrasound scanners. And these techniques measure the stiffness of the liver, and provided that you have eliminated confounding factors like high inflammation of the liver, congestion of the liver, biliary tract obstruction, under any other circumstances, which are quite a large number, the stiffness is proportional to the amount of fibrous tissue. Therefore, by using ultrasound elastography, now hepatologists can assess the amount of fibrosis, can roughly estimate the amount of fibrosis. And this has become a mandatory tool for hepatologists. I would say that no hepatologist can now make a very thorough, complete assessment of the patient if they don't have the possibility to access to elastography. To me, it's mandatory to be a good hepatologist. And as you can understand, stiffness can assess the stage of fibrosis, and this is a bit different for different etiologies. These were data, is a summary of various data that was produced mainly with transient elastography, because this was the first technique that became available on the market. And you can see that with slightly different thresholds, for instance, threshold between 6 and 8 to detect no fibrosis or mild fibrosis from moderate fibrosis, which is the threshold to detect significant fibrosis, or around 13 to 14 to detect presence of cirrhosis. But even within cirrhosis, you have a wide range of stiffness, and this is not meaningless. Obviously, the higher amounts of stiffness help for the management of the patient. For instance, above 17 kilopascal, usually resection of the liver for tumor is not recommended. And also, we can use it to establish the presence of portal hypertension. So elastography is very helpful. It can, at first, rule out the presence of significant fibrosis. And on the other hand, is very accurate to establish the presence of advanced chronic liver disease for transient elastography thresholds above 10 kilopascal. This threshold is slightly different, not only in connection with the etiology, but also in connection with the type of technology. And this is very helpful also in the intermediate cases to assess the situation. This helps to detect the risk of developing cancer. This study was produced in Japan with hepatitis C. You see different thresholds, different risk of annual incidence of hepatocellular carcinoma. And this was helpful also in hepatitis B. These are the studies showing that after 5 years of antiviral therapy, patients with higher stiffness more than 12 kilopascal have 7 times higher risk of developing cancer. So it is helpful to screen patients. And also it tends to correlate with portal hypertension. Therefore, it is utilized to screen patients to be submitted to upper GI endoscopy, which was the other question. Our patients have cirrhosis. Do all of them require upper GI endoscopy? The answer is today no, if we have stiffness measurement with ultrasound elastography. If stiffness is less than 20 kilopascal, concurrently the patient has more than 150,000 platelet count per liter, this patient can be spared from upper GI endoscopy because the risk of having high-risk varices requiring treatment is so low that it is not worth to receive upper GI endoscopy. Therefore, all questions about the liver have been targeted with the new tools that we have, that we can find in new top quality ultrasound equipments. Now I would like to touch and conclude with the final point. In the past, most of our patients had hepatitis B and C. Under these etiologies, extrahepatic manifestations were present in chronic liver disease, but were not very common. You see 2–3% cryoglobulinemia, which only rarely affected other organs, mainly the skin and the kidney. B-cell lymphoma, very rare, 0.5% in hepatitis B. In hepatitis C, B as well, there were extrahepatic manifestations, but ultrasound was not useful at all. Therefore, in viral heretic chronic liver disease, extrahepatic manifestations exist, but they're not very common and do not deserve additional ultrasound investigations unless prompted by clinical or laboratory findings. However, now we are facing a new wave of chronic liver disease caused by non-alcoholic fatty liver disease. This is usually associated with the metabolic syndrome, and those who have fatty liver disease with metabolic syndrome, who are older and also have diabetes, are the ones at higher risk of developing cirrhosis. Therefore, the EASL, these are the Society of Study of the Liver and Obesity and Diabetes, the European societies, recommend that all individuals with steatosis should be screened for features of metabolic syndromes, which I remember are not only fatty liver, but are hypertension, are increase of the circumference of the abdomen and increased BMI, and the increase in triglycerides, plasma triglycerides, and they should be screened for these features independent of liver enzymes, even when the liver enzymes are normal. And if the liver enzymes are abnormal, they should be screened to have non-alcoholic fatty liver disease, because they're high, they bear a risk of having advanced chronic liver disease without being aware. I mentioned the etiology in liver cancer, and up to 2013, the increase was from 2.2 to 9%. But in recent years, the trend to an decrease in etiology related to the metabolic syndrome has been really exploding. And now we've come to 50%, and I can tell you that in our ultrasound labs, even in the last weeks, more than 50% of the new diagnoses are related to patients with non-alcoholic fatty liver disease. Why is this important for us, that the etiology is so fast changing? Because fatty liver disease is related to the metabolic syndrome and to extrahepatic manifestations, which are not rare but are very common. In fact, cardiovascular disease are the largest, the most common cause of death in patients with non-alcoholic fatty liver disease. As you can see, hepatocellular carcinoma and cirrhosis, together with extrahepatic neoplasm. I would like to remind, for instance, that obesity is associated with an increased risk of colon cancer, of breast cancer. These are the main causes of death. So it is not the liver itself the main culprit for the risk of death in patients with non-alcoholic fatty liver disease. So we have to keep in mind to look at the other organ, because if we forget and we just stay the patient, oh, you have fatty liver disease, no cirrhosis, you can stay still, peaceful, nothing will happen. This will be a damage for the patient. We have to keep in mind that these patients are at risk of coronary artery disease, hypertension with the consequences of the heart, cardiac arrhythmias. So we have to screen. And this is particularly relevant in patients with NASH and advanced fibrosis. We don't know why, but more advanced liver fibrosis is usually associated also with more advanced cardiovascular disease. Therefore, we have to keep in mind that when we make a diagnosis of non-alcoholic fatty liver disease, it is very important to evaluate the marker of subclinical atherosclerosis, which means carotid intimal medial thickness, and this is where ultrasound is important. And also, we can even look at the coronary themselves with the CT calcium score. Therefore, since cardiovascular complications frequently dictate the outcome, we must detect this complication early in order to treat this patient for cardiovascular disease. Therefore, we start from the liver, but to move to cardiovascular system. And this is done with ultrasound, extending the ultrasound examination beyond the liver to the carotid investigation, if not previously done, and also to the kidney, because patients with cardiovascular disease and diabetes often suffer from chronic renal disease. And this has to be done again with ultrasound as a first screening method by measuring renal cortical thickness, kidney echo texture, and the volume and size of the kidney to early assess changes that in diabetes usually start with enlargement and later with the shrinkage. And this is easily detected by ultrasound, not mentioning that these patients often suffer chronic renal failure, which prevents the use of contrast agents for radiology. Just to conclude, as you could understand, we screen our patient, we detect non-alcoholic fatty liver disease, we stage the patients with stiffness, and we can subgroup them according to the stiffness. And this is related to different overall survival probabilities. So patients with cirrhosis obviously has a worse outcome, but moderate severe fibrosis have slightly better outcome, and the best outcome is patient with no fibrosis. You could think that this is only a cause of liver disease. However, what is clear that survival after exclusion of liver-related death is also related to the severity of liver stiffness. Therefore, with ultrasound, we can do a very thorough assessment of the patient, which does not only relate to the investigation of the liver. In the liver, we are perfect, but we must do more and investigate the patient for other conditions. And with the new technologies that we can find on the best equipment that we have to date, we can really make a very good service for our patients, make accurate diagnosis, accurate prognosis, optimal management, and hopefully improve the survival of our patients. Therefore, this is why ultrasound is the only one-stop shop for modern management of liver disease in the current time of metabolic disease. Thank you very much for your attention.
Thanks a lot, Fabio. Is there any questions from the audience? I don't see any. So because we are just a bit in delay, I decide that we can do a discussion at the end of all the presentation, if you agree, of course. Thanks a lot, because now my role is very easier, because you did show a lot of different possible clinical information. And give me 1 second, because sometimes, no, okay. Okay. So after the clinical presentation by Fabio, right now my role is to show you what we can do with the new softwares. Let's start. This is my agenda, and my agenda will provide you the clinical and general technical background already provided by Fabio, so it's done. Then I will show you what the new Samsung software may allow us to quantify steatosis. Then we move for fibrosis, and providing also the possibility to extend our evaluation on carotid. We know that liver is the main metabolic organ in our body. And we have to ask to all of us the 5W. Let's start to try to address these questions. From fatty liver, unfortunately, this patient can develop, at the end of this clinical pathway, liver cancer. And we have two main reasons that we need to quantify hepatic fat, because it may predict future diabetes development, cardiovascular event, and fibrosis. We are aware that it is easy at histology to depict the presence of fatty content. But in this editorial, some years ago, we started to address what it is really important in FRD, saying that biopsy, although it is still considered the gold standard, is also related to high number of serious events. But what about ultrasound? Fabio already showed you that unfortunately it is limited. But every day we evaluate patients with ultrasound, and we know that ultrasound signal changes its three properties through fatty liver: the amplitude, variation of frequency component, signal scattering degrees, and the corresponding result is the brightness of the liver. However, we have right now different grading systems that try to allow us to differentiate grade 1 to grade 2 to grade 3. This one is the Yamaguchi one of the most used. We use all these features to try to understand if there is steatosis and what kind of grade. Then we also go to understand what are the limitations. And one of the main limitations is the inter-observer in the intra-observer variability, as shown nicely and precisely by Strauss and colleagues. What about TE, Transient Elastography in FRD? Unfortunately, to now we can use to exclude cirrhosis, but not to grade NAFLD grades. What about new quantification methods? Samsung provided us the possibility to evaluate echogenicity ratio of liver on the basis of kidney brightness, the attenuation of ultrasound signals on liver, and the backscatter on ultrasound signal. Let's move on and try to show you the first one, the Hypoto renal index with automated ROI evaluation. And how to do it? You choose the right image, then you freeze the button, and then automatically two ROIs are depicted and reported within the liver and the cortex of the kidney. And as you can see here, depending on the different content of fat corresponding to brightness of the liver, you can have different number. So you start your evaluation with ultrasound, then you select the best image, and then you press the button of the software, and at the end, you have the number corresponding to it. In literature, some papers are starting to appear. There is one from Marshall, which showed that HRI measured than 1.28 has 100% of sensitivity. However, specificity is quite poor. But in that study, they showed that they were able to reduce the number of necessary biopsies. Now let's move on to another possibility to quantify fatty liver content. And to do it, you have to follow strictly the protocol techniques. This is the same one that you have to follow also for shell wave elastography. Firstly, you have to scan the liver within the intercostal approach with maximum 6 centimeters. Patient should fast at least 3-6 hours. No alcohol injection for at least 12 hours. Then you have to be far from the heart, avoid vessel within the ROIs, and ask the patient not to deep breath, but only to suspend it. And this is schematic view that you have to achieve. We have right now the possibility to use TAI, tissue attenuation imaging. The attenuation gradually loss because of due to absorption, reflection, refraction, and scattering. What is really useful in this machine, you have a quality indicator that is available and it is online in real time, and if the numbers are colored in red, you have to repeat. Let's have some examples. You put your color box, you have a polychromatic box corresponding to the values, and then at the end, you have your numbers. Should be perpendicular to the capsule, should be far enough from the capsule, 1 to 2 centimeters, and try to avoid significant presence of vessels. And you can stratify the normal from mild, moderate, and severe steatosis. I summarize here my tips and tricks to obtain the best results. But as I told you, we have a quality indicator that should be at least 0.6, or some others are saying 0.3, 0.4. Then what you have in real time, you have yellow or red. So you choose yellow one. TSI, other software, based on the scatter distribution. And this may help you to discriminate if there is more inhomogeneity within the distribution of fatty content. So you may have a normal liver or fatty liver. Again, numbers, cutoff varies. Cutoff are important, but unfortunately, I start to say to all of you that any equipment has different cutoffs, and we are working really hard to find out, prove it by higher and larger number, which are the real cutoff. Again, already in the literature, some papers reporting about the numbers and about the fact that both TAI and TSI may correlate with TE, with control attenuation parameters, in discriminating the presence of fatty content. What we usually do every day right now, we start with baseline, we move to ZE, to EZHRI, then TSI, TAI, and then at the end you have this report, and you can grade according to the number, the grade of steatosis. What about fibrosis? It is really challenging. Still, right now, we have multi-modality imaging evaluation. And I suggest you to read this very nice paper from Smith. He tried to address what are the main indications and introducing elastography. Why elastography? From Hippocrates, we started to use palpation as an essential part of physical examination. However, we know that it is limited by operator dependency, by the depth and the size of the lesion. Therefore, technology is helping us to do the elasticity imaging that is based on tissue stiffness or deformability rather than anatomy. And that's the potential to really objectively quantify the stiffness. We have two different elastography methods, strain, shear wave. For liver, my answer is no strain, shear wave yes, because provides quantitative evaluation. In the market available many actors, and most of us may be astonished. But I try to summarize in this scheme what we can have from transient elastography till to the MRE, focusing on ultrasound elastography that has a very good role to differentiate advanced fibrosis, moderate role in differentiating early fibrosis. This is something that is right now changing, and it is very widespread, and the cost is really lower compared with CT and MRI, and is applicable, however, in daily life. Again, protocol, transient elastography, point shear wave, to-do shear wave, the same one as I showed you earlier. In the literature, cutoff were mutuated firstly from TE, but parallelly, Sherway is trying to show that we can achieve similar results, but with different cutoff. So be aware about it. Again, I want to stress on this concept, because unfortunately, we cannot use the same values with different equipments. Again, we wrote this editorial some years ago, and we tried to address what were the limitations at that time. One, for sure, the absence of quality criteria. Secondly, the inter-observer variability. Recently, together with Fabio and Lorenzo Morazzani, we published this paper in which we tried also to give protocol advices and the numbers. Let's move on, focusing on what this equipment may allow us to do. Again, we have a reliable measurement index that helps you to do in real time the right evaluation. And how to do it? I try to summarize it. What should do an experienced operator? Again, distance from the capsule, taking consideration the skin-liver distance. Then you look at the main value, the standard deviation, but here is what is really important to decide, yes, I keep or not this evaluation, RMI. According to our preliminary experience and to what is present in the literature, we are using RMI above of 0.3, 0.4. Then you have to look for IQR less than 30%, and we are reducing the number of measurements. With this machine, we found that with a cutoff of more or less than 5, we can state normal liver. 5 to 6, borderline F1, then F2, F3, F4, depending on the values included in this table, more than 9.6 cirrhosis. Again, how difficult could it be to say 9.6 cirrhosis, 9.7 or 9.5 not cirrhosis? Let's see how to do your evaluation with some example of different numbers corresponding with different grades. Again, we start our study. We evaluate following the right protocol. And then at the end of our examination, we look at RMI, and then we have the median value and look at IQR over median. That should be less than 30%, and then we can conclude dialysis. Let's look at this case. Typical cirrhotic patient already at baseline. Look at the number, very high, very stiff liver. But what is really the main advantages of 2D shear wave elastography? In that case, we did find also this lesion. Color Doppler, Lumiflow, new software provided by Samsung, which provides you a 3D resembling vascularization within the lesion, and then CUS to conclude that this is an ACC. We have to take in account how important is to learn, to practice before doing. And the period that still is not standardized, we are discussing between the experts. How many cases should be done before you can really determine it to do your examination reliably? And then another important thing, cutoff values, variability. Unfortunately, systems have different values. So you have to look at the literature, at the guidelines, and most probably, as experts, we have to put together our knowledge to provide you a vademecum on the cutoff values. Guidelines, they are uploading for free on our website, on Epson, and then you can find all the information that I already told you in advance, with recommendation to use shear wave elastography for sure to rule out fibrosis. I showed you how to manage liver. This is a suggested report. When you write your report, describe your baseline ultrasound, then you have also to show and to report what is the equipment you are using, what is the probe you use it, and follow guidelines and use papers to provide a final conclusion. Therefore, describe ultrasound features and grade possible statosis, then describe the quantitative evaluation, then the liver stiffness value, and also consider the clinical setting in your report. Let's move on to extend beyond the liver our evaluation. And we have to start trying to address some questions such as, can ultrasound be considered gold standard in the evaluation of IMT, wall alteration, and carotid stenosis? Can we assess with ultrasound plaque vascularity and composition? And what about the definition of plaque vulnerability? We started our experience with the previous equipment, and we did achieve also some prizes. One of my fellows was recently awarded at SIUM Congress, presenting our results on the use of 3D arterial analysis. The 3D arterial analysis is a software that is installed in Samsung equipment with a 3D probe that can allow you to analyze and assess the arterial shape by means of 3D evaluation. It automatically calculates the displacement of the wall motion, both longitudinal transverse assessment. It provides also the area and volume of the plaque and the prevalence of the content. Here is an example. So you have a 3D visualization that surgeons are really love. And then you can delineate, contour, drawing the internal part of the lesion. And then you have the percentage of the area, of the volume, and then also the possibility to depict with different colors the different content of this plaque. But technology is really improving. And right now, we have also the possibility to do the auto IMT correlated with Framingham score and with different age and all the features of the patients. And then to the arterial analysis. It provides information related to vascular wall stiffness, the displacement of the wall in real time, trying to predict what can happen to that patient, especially related with fatty liver disease and chronic kidney disease. You can do your examination using long axis, and then you can achieve the evaluation of radial, longitudinal, or with area, and then you evaluate displacement, the radial strain, the near-far strain, the radial velocity, the near-far velocity. You can also draw your contour in linear type with box or with circle. Then you start your analysis, 2 seconds, analyzed by the machine, and then you have the displacement of carotid wall during that time represented by a graph. You can assess easily and precisely the IMT. And what about literature? Some papers are starting to appear, and all of them are showing that also in this typical clinical scenario, circumferential strain of common carotid artery might serve as a marker of atherothrombotic stroke in order to stratify the risk. Also related with end-stage renal disease. However, we are really at the beginning, and I would like to show you one case, baseline imaging, with this typical inhomogeneous, fairly marginated plaque. Then we use MV flow with LumiFlow. We assess velocity peak velocity that is not so high. And then we 3D the percent of stenosis, with also the possibility to depict the vulnerability of the plaque, features confirmed at MRI, and we started also to use 2D arterial analysis, trying to address at the level of the plaque with two different views if the plaque provides a differences in the hardness of the wall. Look at here, at this part where the plaque is not so big, the other part where it is thickest. The resembling hardness blended evaluation is clearly more visible. And then we are also starting to understand which are the parameters that we need to address and to use properly to prevent the possible complication of this disease. Then we evaluate the intima media thickness, and we are also starting to evaluate the vector trajectory projections of the displacement of the wall. In conclusion, color Doppler ultrasound, with all these features, can really provide us useful information for the plaque and the stenosis evaluation, but also in this kind of patient with NAFLD to try to stratify the risk of the evolution of cardiovascular or kidney disease. Take-home messages: multi-parametric ultrasound needs to be done in the appropriateness of examination, needs adequate training, instruct the patient to collaborate with you. Then use the suitable parameters, because if you do that, multi-parametric ultrasound is always advised. But again, follow the guidelines, be trained and familiarize with all the equipment functionalities. And then try to address steatosis, vascular disease, in order to reduce intra and interobserver variability. This is a liver? No. This is a reverted colosseum. And I hope that this pandemic will end. We will have this rainbow and to host all of you in our facilities. And I thank Daniele, but all my group, because otherwise, without the help, also my cooperators, all this stuff cannot be really done as proper as we did. I hope to have given you the tips and tricks. Is there any question from the audience?
Yes, there are two questions, one for the
Okay, let's address the question. What is the cutoff measurement of carotid intimal thickening? Well, we have to stratify according to the age. In general, below 55, 6 years, we usually follow 0.9 median values. Between 55, 60 to 65, we use a range that comes from 0.9 to 1.1. When the patient is older than 65, 1.1. And this is the median values that are used to now. However, the cutoffs are changing. Then let's move on. Okay, the other question is about children. We are also focusing on children. Unfortunately, to now, honestly, not so many papers are allowing us to conclude and to recommend, as we did for adult patients in our guidelines. Therefore, we need to work specifically to find out the new cutoff and also indications and limitation. And I would like to inform you that we just started a specific protocol on pediatric patients. And if someone of you, or you, Daria, would be interested to be participating, send email to me. I will show you, I showed already, but you can ask also to Samsung or also directly to me, and then I will give you the possibility to share the data. Yeah, Fabio, there is a question for you. What is the prevalence of fatty liver? Fabio? It depends. I can answer, although I'm not an hepatologist, but the prevalence is depending on the countries. In Italy, we are in a range between 10 to 30%, and it is increasing every year. It depends on the attitude and the countries where you are working with and where you are living. But the prevalence again is increasing. So far, now there is the last part of our webinar that I shared with Daniele and with all the others helping us. And I hope that Jules or someone can just start the first video showing you the tips and tricks on how to do liver evaluation. Thank you, and we will come back again for other questions later.
After the theory and the clinical background, now let's move on to what we can really do in daily practice with the real patient. And I choose not easy patient, moderate severe obese patient with metabolic syndrome. And to now, we need really, and to us, is really requested to assess the severity of steatosis. Secondly, to evaluate if there are other incidental findings to be reported. We have to remind to all of us that as the signal passes through a fatty liver, such changes can be measured in terms of three properties that can really alter it based on the degree of the deposit of the fat. Firstly, amplitude. Secondly, the variation of the frequency component and the degree of signal scattering. And what we do really, firstly, we evaluate with baseline. So we do our normal evaluation, and with normal evaluation, we look for the echogenicity of the liver parenchyma compared with the cortex of liver. And then, if you look for the visibility of the liver parenchyma capsule, the visibility of the vessel, and the presence of skin areas, and the general scattering and attenuation of the signal coming from liver parenchyma. But unfortunately, this is subjective evaluation. If I ask you, this is mild, moderate, or severe, the answers can be really variable. Therefore, Samsung try to give us, to provide us different softwares that can allow to evaluate the echogenicity, the attenuation, the backscatter. Firstly, you have to remind what is HRI. It is the rate between the brightness of the liver and the brightness of kidney. And you freeze the image, then you look at your screen, and then you press Tab Easy HRI button, and automatically there are two different ROI, one within the liver parenchyma, one in the cortex, and you can also move and change and adjust if you don't like. But automatically, this is what was reported. Then you press your button, and this image with this value is saved. We suggest to everybody to measure 5 times with this software. And then at the end, you will have your report. Remember, patients should fast for at least 3 to 6 hours. Secondly, the position of the patient. Thirdly, the position of your probe, of your hand. And then you have to be aware on how the equipment works. And then you continue with your evaluation. Please stop your breath, then you find the right image. Again, you press the button and you have this evaluation automatically. Then you can move and you can change. And you press and again you save. Then stop, 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 and again, and you repeat for 5 times. Stop, stop, stop. Again, and again, you save. Please stop again, again, you freeze, you save. Stop again, again, and you freeze, and you have your measurements. But we can go even furthermore in the evaluation of this liver parenchyma. I suggest you to read all the papers I showed you in my previous presentation to find out how to overimpose your probe in the right way. And then, when you find the right window, you can press the Q quantitative ultrasound button, and then you find TAI and TSI. Therefore, with TAI and TSI, you can have the measurement of quantification of fatty content. And all these methods provides you different values. According to them, you can really obtain different possibilities to assess the severity of liver steatosis. TAI button, you press, you can have this, and then automatically you have this row, the box, and then a color that indicates with the red one that this is not good. You have to be perpendicular, but in this image, too many vessels. Therefore, you move below 2 centimeters below the capsule, and then you have the right value, and then you save and you obtain this value. Again, stop, 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 you press again, and then automatically this one is okay. You have the yellow signal, so you can move towards the new measurements. And then again, stop, 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 press again, and again red, so you look for the right image, but most probably this one should be skipped. So you repeat automatically. Stop, please, stop your breath. Again, you can have the right signal, and then you save. 3 measurements now. Stop, stop, stop. Red, so I move towards the right one, perpendicular, and then far enough from the capsule, and then you save the 4th. Stop, stop, stop. Red, again, so I skip. Stop, and then you find the right one, and this is the last one. Now we move to a TSI. A TSI will allow you to the quantification of the scattering of the background signal. So the first one is based on attenuation. The second one on the scatter of the signal. Let's move on, and I'll show you how to do it. Again, find the right image, and again, you press TSI, and then you have the value. The first one, stop, stop, stop. This one, too much vessel within, so I will choose another one. Stop, stop, stop. Then I find out that this is good. Again, the third. Stop, stop, stop. The 4th. Again, stop your breath, please. Stop your breath, please. And you find the 5th. At the end, you may have your final report. And all the different features that we have to now measured are calculated automatically. And if you look at the general numbers, this is a mild steatosis. At the beginning, we were not really convinced about the grade, But then, if you look at the number that are coming from our preliminary results and what is already present in literature, we can confirm that this is a mild steatosis. Thanks a lot for your kind attention, and let's wait for some seconds for another demonstration on the carotid evaluation. Thanks a lot. See you soon, I hope here in my unit, here in my department. Bye.
Hey everyone, today I would like to show you our ultrasound application about the hepatic fibrosis evaluation, in particular with the shear wave elastography. At first, in according to the EFSUM guidelines, it's important to have a right position of the patient in a supine position with the right arm in maximal elevation in order to open the intercostal space where we can put our probe and evaluate the liver parenchyma. So we can start with our B-mode evaluation and switch on the shear wave software. We ask to the patients to suspend his breath, stop, and put the chromatic box inside the liver, at least perpendicular to the liver capsule, at least 1 centimeter below it, and avoiding the hepatic vessel and bile ducts. Within this box, we can evaluate the elastosonographic values with some ROIs that we need to save. It's important to evaluate one of the quality controls of this software, that is RMI, that is adequate if it is higher than 0.3. At this point, according to the EFSUM guidelines, it's important to obtain at least 3 measurements. In this case, we have obtained 4 measurements. We have performed our examination and we can see the final report. In this report, we can see all the shear waves values individually and as average and median value. And there is an important quality control parameter, that is the IQR, that is adequate if it is less than 30%, as in this case. These values are with the healthy liver. Thank you for watching and arrivederci.
In addition to what I showed you for liver parenchyma, as already reported and explained to you by Fabio Piscaglia, in this kind of patient we need to evaluate not only liver parenchyma, but in addition also carotid artery. And in the same examination, with new tools provided by this equipment, we can provide a real evaluation of the media intima thickness evaluation, and secondly, the evaluation of the radiation force with the 2D arterial analysis. Let's show how to do. I want to remind to all of you that patient should be in the right position. The probe should be covered by gel, and then you start your examination. Find the right image and start to evaluate your carotid artery and your carotid artery. Stop. In order to assess the media intimal thickness. What is available in this machine is different other tools that can help you to obtain a medium average measurement of the media intimal thickness, and then you can start analysis, and this machine automatically report to you the correlation between the Framingham risk score and the intima media thickness. Then you can also obtain, corresponding to the age of the patients, what is the risk factor with this intimal medial thickness, and then the value of the patient is reported really nearby the highest level of the normality still. And finally, you can also have other possible graphs that try to help us to provide the stratification of the risk. However, technology is improving, and right now we are looking for the displacement different alteration. You choose your image and then you start your arterial analysis. For 2 seconds, the equipment analyze and evaluate the movement and the displacement of the wall. After that, you can choose if you want to draw a line or a box or a circle. Let's start with a line. We press and we obtain the contour of the intimal. Then double click, go to the other one, repeat, contour, drawing the internal part of your image, double click, and the machine allow you to understand that this is a normal contour, so does not like this image. I repeat, and you can choose also to do specific stop evaluation also with axial line. Then you choose the circle and you draw very easily again, and then you start your evaluation. What you can have in this display, you can see the different possibility. You have the image only, with the graph corresponding with displacement. Trajectory 1, showing you how, during the time, there is an evaluation of the displacement of the wall. Then you can have also other possible tools. And finally, also the velocity vector. And you can choose also a different way to represent the displacement during the time. We just started our evaluation. We are trying to understand which are the best parameters to be taken into account to stratify the risk of the evaluation of this carotid artery. But I believe that this is the future. We are just at the beginning of this workflow. And we are very enthusiastic to be among the first to try to understand how these new softwares may allow us to obtain a proper examination of this kind of patients. Thank you for your attention.
Hello again. I hope that all the videos satisfied your expectation. This is the first try. Therefore, I would like to apologize for the quality, but next time we will do even better. But Fabio, we need again to continue to answer to several questions that arrived. There is one, most probably for you, but we can answer together, from Vasiliki. Is it possible to have normal stiffness values in a liver with regenerative nodules?
So you mean that you see regenerative nodules and the surrounding parenchyma is normal stiffness values? Well, actually, this rarely happens in cirrhosis, and in my experience, this is happening only when the patient has reached the stage of cirrhosis, but then you treated hepatitis B, or he stopped completely to drink alcohol, or hepatitis C was cured. Sometimes over the years, the stiffness values go back to normal, but the regenerative nodules of cirrhosis may remain. This is relatively rare. Otherwise, you might think whether these are really regenerative nodules or are biliary hamartomatosis or other condition that you named regenerative nodules, but indeed they're actually not regenerative nodules.
I totally agree with you, and I have also to have some more information for everybody of you. We did start some studies in the past, then we have to repeat with the new softwares. But at that time, we were not able really to discriminate focal liver lesions with the stiffness values. And that was one of the reasons, because in the last EFSUM guidelines, we did not suggest to characterize liver lesion according to Sherwave. However, this is an important field of research, and I hope, Fabio, that we have to joining again to try to see if the with new softwares we can achieve better results. Let's move on with the other questions, and I thank Irves Vidi for several questions in a row, and I try to address them. Although I have to say that right now the evaluation of the new equipment started just few months ago. Therefore, I can only refer to the impression of we have having, because as you know, I like to collect all the cases, then to send anonymously to the statistician, then to have the ROC curves, and then to provide you the real numbers that we need. However, in our first preliminary experience, and also according to what is right now published in the literature, related on not so many patients, we have to say cutoff value for TAI and TSI for light, middle, high. For now, I can answer to you, TAI normal is between 0.6, 0.65. In literature, there are other studies with other equipment that stated cutoff of 0.64. Again, I don't like when the cutoff is really too much tough. 0.64, Fabio, I don't know if you agree. It's probably, okay, it is a number that comes from ROC curve analysis. But in daily life, it's very complicated to use. But to now, the impression is 0.6 until 0.6 normal, 0.6, 0.7, 0.8 middle, mild, moderate, and then more than 0.8 severe for TAI. However, I would like to remind you that we need robust data, and I will provide you soon after I will achieve more than 100 patients, because this is more serious and more scientifically. About TSI, less than 90 normal, in my impression, 90, 100, mild, moderate, 105, 110, more than 110, most probably severe. Then, again, Ilves asked me the utility of MV flow and LumiFlow. Is any other softwares that purify the color Doppler signals? Regarding the utility, they try to enhance the capability of our evaluation to depict the presence of vascularization within the plaque, and also to better evaluate the ulceration of the plaque. However, I usually use all of them, but if I have really the suspicion of complicated plaque, I suggest to submit the patient to CUS, and usually I'm doing that, and with CUS I achieved better results. About the 3D analysis color map, what we usually use is an additional value in order to confirm the suspicions of our vulnerable plaque. We did our study in comparison with histology, and the preliminary results were not bad at all. We achieved a very coherent comparison with the final histology. Therefore, this can be another possibility to us. And then there is another question, but for you, Fabio. NAFLD is a risk factor for ACC, but can steatosis hide focal liver lesions? How can we solve this problem?
Actually, this problem at the moment cannot be solved because obviously some lesions are hyperechoic, some are hypoechoic, so depending on the background they might be hidden, as someone has already correctly stated. However, with improved ultrasound equipments, you can even detect from the mass forming aspects of the lesion, even isoechoic lesion. So the sensitivity is improved, but obviously no technique will reach 100%. But at present, ultrasound is still the most cost-effective technique. So we cannot scan with MRI all patients with steatosis. We cannot submit patients with to the hazard or radiations with CT. So despite the limitations that are decreasing, we still need and have to rely on ultrasound.
Thanks, Fabio. I totally agree with you. And the last question from Rogerio Augusto Pinto Silva. What about SRU consensus? Do you use it as a reference tool? With Richard Barr and other experts from SRU, we are talking and discussing to find a way to put together SRU and EFSUN to try to have a common consensus. However, if you look at the numbers that I showed you coming from the paper that together with Fabio, we wrote on Journal Hepatology, the cutoff values were very close to the ones provided by SRU. And I totally agree that we need really to be more close, because unfortunately, otherwise, any society provides different values. This can be confusing. But just today, I received this email from Richard, so I believe that SRU, EFSUN will join very soon to try to find out a way to provide a common consensus. Do you agree, Fabio?
Yes, I agree. Obviously, I would like just to mention one of the limitations that we addressed in this editorial, which attracted many citations about the many actors on the stage, means that many equipments have become available for elastography. But until 10 years ago, we had the possibility to take biopsy in many patients. So it was easy to run new studies and establish thresholds. Nowadays, there is less need for biopsy because hepatitis C can be treated, hepatitis B can be treated, so we don't need biopsy to treat these patients. Therefore, it is more and more difficult to run new studies and to establish the perfect thresholds for each disease and for each equipment. So in the end, I believe that we need some observational studies and come to agreements even without strong evidence, because the strong evidence can never come.
So we have a lot to do. We are just at the beginning of our journey towards the optimal evaluation of this kind of patients. Time is running. There is another question. Oh, yes. Okay. Yeah, I totally agree, Rogerio. Rogerio agreed about the universal reference, although it's not easy, because as you know, any society has some specific ideas, but we will try for sure, as always we do. And what I like of our societies, the Italian one, the EFSUN ones, is that we try always, and BUFUM as well, and SRU, to find a common agreement. Because what is really important is to have protocols, rules, recommendations, guidelines for all of you. Time is running, 7:30. I hope that this webinar satisfied your expectations. I would like really to thank Fabio again, Daniele again, June and Samsung for giving us this opportunity tonight to inform all of you, because our first mission is to educate, then to do research, but never, never forget that we need to do everything that we are doing for the better cure of our patients. And this is our main activity. And I'm proud to be part of the expert group and I learned a lot from Fabio and the others. And now we are trying really to have a universal consensus in order to make everything under protocol. Jules, would you like to tell something at the end of this session?
I'd like to thank all the speakers, Vito, Fabio, and Daniela. But most of all, I would like to thank all of the participants who have joined us from all over the continents. Please take your time to participate in the survey, please. And please join us at the next EFSOM webinar sponsored by Samsung on April the 22nd at 6 p.m. Titled Diagnostic Performance of Contrast in the Evaluation of Cystic and Solid Renal Masses. Have a great day, everyone. Thank you, Vito, for the excellent job that you've done. Thank you very much, everyone.
Thank you. Have a good night. See you soon, especially here in Rome or in Korea or wherever. Bye.
Thank you.
Ciao.
Bye.
Thank you, Fabio. Thank you, Daniela. Thank you, everyone.
Bye. Thank you.